Good morning, everyone. I am Rahul Gosain.
And I'm Rohit Gosain.
And we are Oncology Brothers. Today, we're joined by Dr. Joshua Royce, who's a thoracic medical oncologist at the Georgetown Lombardi Comprehensive Cancer Center. He's also a recent recipient of Longevity 2022 Career Development Award for his ongoing work. In our discussion with Dr. Royce, we're hoping to focus on clinically relevant lung cancer studies that were recently presented at ESMO 2022. Without further ado, let's welcome Dr. Joshua Royce.
Thank you very much for that introduction. I'm happy to be here and looking forward to an exciting discussion.
Thank you, Dr. Royce, for being here and taking the time to go over the clinically relevant studies that were recently presented at ESMO 2022. Let's start off with our first study, update for DORA trial. Osimertinib was approved in adjuvant setting for lung cancer patients with EGFR mutation. Can you please walk us through this recent update and how are you implementing this in your own practice?
Absolutely. So just as a recap, this study definitely turned a lot of heads with the data when it came out and definitely injected a lot of controversy into the perioperative setting. This was a phase 3 clinical trial of the third generation EGFR targeted therapy osimertinib in patients with completely resected stage 1B to 3A non-small cell lung cancer by the AJCC 7th edition of staging. Patients were randomized 1-to-1 after resection to either 3 years of osimertinib therapy at the recommended phase 2 and FDA-approved dose of 80 milligrams versus 3 years of placebo, primary endpoint being disease-free survival in those with stage 2 and 3A resected non-small cell lung cancer. Importantly, adjuvant chemotherapy was recommended as appropriate by the treating physician, but not required. Now, this study was a positive study for disease-free survival. The hazard ratio was 0.17 in that population. In the stage 2 to 3A population, in the whole population, that hazard ratio was 0.20. And importantly, a CNS disease-free hazard ratio was 0.18 in favor of osimertinib. Again, this was in the original data that was published, leading to the FDA approval of this therapy. And this reason this really generated controversy in the academic community was because this, for one, was a disease-free survival benefit. We don't yet know whether or not this therapy will lead to an overall survival benefit. And there's been quite a few prior studies of adjuvant targeted therapy of early generation EGFR targeted therapies that saw a disease-free survival benefit, albeit not with a hazard ratio this promising, but then ultimately did not result in an overall survival benefit. So I think we were very excited for this update because this is now an update at a median follow-up of 44.2 months. We're now seeing how this data is changing. At least we're starting to see how this data is changing for those patients who are now off of those 3 years of osimertinib. And so the data here at 44.2 months, again, at around 4 years follow-up, 51% maturity, we still saw a disease-free survival hazard ratio benefiting osimertinib in all populations. But we're starting to see these curves creep a little bit closer back together. We're starting to see the slope change a little bit. Importantly, and I think you have this on your slide here in the bottom right, you could see kind of where the slope changes for incidence of recurrence, both in the CNS and systemically, for those who were on osimertinib, suggesting that after that 3-year time point, there is a waning effect of the EGFR TKI, where we're starting to see recurrences after patients stop the EGFR TKI. And so while I think overall, this study did in many ways reaffirm the clinical benefit of adjuvant osimertinib for those with resected EGFR mutation positive non-small cell lung cancer, and just to specify, that is for those with EGFR exon 19 deletion or 21L858R mutation, I think it still raises many questions, such as, will we see an overall survival benefit, as these curves start to come together, as we see crossover for those who have recurrence? Does this suggest that we need to keep patients on the targeted therapy longer for those that have stage 2 and 3A disease? And I think what's very important, and it was often overlooked, is that the frequency of CNS imaging for patients with EGFR alterations. And so I, in my practice, do perform a yearly brain MRI for my patients with resected EGFR positive non-small cell lung cancer. And I think knowing that the rate of CNS recurrence does go up after discontinuation of EGFR targeted therapy, I think it raises the question of, do we even need to consider more frequent CNS imaging in those patients? So.
No, I appreciate you going over that. But can we extrapolate this data to something else as well? So patients that are stage 3B or stage 3C that get concurrent chemoradiation and have EGFR mutation, in those patients, do you consider osimertinib, or do you move forward with Pacific trial and consider immunotherapy as maintenance?
Yeah, no, very, very good question. So, and one that is being addressed by, I believe, the LAURA trial, which is a study of adjuvant osimertinib following chemoradiation. I think that is definitely a decision that academic oncologists weigh. They go back and forth. I, in my practice, prefer not to prescribe the durvalumab in the adjuvant setting if I know of a classical EGFR alteration that has efficacy for osimertinib. In that setting, I definitely will consider osimertinib in the post chemoradiation adjuvant approach. Though obviously we do still need data for that. Definitely getting NGS on all these patients is important. It's no longer just for the metastatic setting. For locally advanced, that's important. And I think, it depends also a little bit on the type of EGFR mutation. If you see a more atypical EGFR alteration where osimertinib does not have proven efficacy, I would be a little bit more hesitant to recommend it in that scenario.
Perfect, thank you. That's a great segue to our second study, where we're going to look at the importance of NGS and stick with the same topic of EGFR mutated patients. We continue to struggle on what to do for these patients in second line once they've progressed on first line osimertinib. So here we're looking at Insight 2. Dr. Royce, could you walk us through this study design and its findings?
Absolutely. So as we know, EGFR targeted therapy with osimertinib, while the response rate is high and initial response is robust, the duration, unfortunately, is shorter than we would like. The median duration of response is on the order of 18 months. So while we always can anticipate a high initial response rate, ultimately these patients do progress, and we can see many things in that situation. And I think it raises the first important point that in the setting of progression on EGFR targeted therapy, it's always important to repeat a biopsy. In my practice, I like to get both a liquid tumor biopsy and ideally a solid tumor biopsy as well. Because it's important to identify not only are there bypass mutations, both that are in the EGFR pathway or outside of that, leading to cancer growth, but also are we seeing histologic transformation? Because if we do see transformation to squamous cell non-small cell lung cancer or small cell, that will definitely impact our treatment strategy. And one mechanism of resistance that we do know exists is MET amplification. It's one of the more common mechanisms of resistance seen in the setting of EGFR TKI resistance. And there have been several studies that have looked at adding in MET-specific therapy in the setting of MET alterations following EGFR targeted therapy. And the data we saw here was from the Insight 2 trial. So this study, a 2-arm phase 2 study in advanced EGFR mutation positive non-small cell lung cancer with MET amplification after progression. In this study, patients were enrolled and received the tepotinib therapy with osimertinib, and then there was an additional small arm of patients who received tepotinib monotherapy. And these were initial results of this trial. A total of around 120 patients were enrolled. And importantly, it's important to note that the definitions for MET amplification here, because these vary. We don't have a strict criteria for that. And in this study, they allowed for a MET gene copy number greater than or equal to 5, or a MET CEP7 ratio greater than or equal to 2, and or a liquid NGS biopsy of MET copy number gain of greater than or equal to 2.3. And I think these results were quite exciting in the sense that for those with MET amplification, detected by central fish, we saw response rates on the order of 45 to 55%. And importantly, tepotinib monotherapy elicited an overall response rate of only 8.3%. And this was in a small cohort of patients of 12 patients. So I think the important take-home points here are that this MET amplification is potentially actionable. It is reasonable to consider the addition of MET-targeted therapy to osimertinib. And importantly, uh, the tepotinib monotherapy by itself is not enough. We know that just switching to tepotinib is something that is insufficient in this scenario. And I think Helena Yu brought up a good point in her discussion, is that these alterations, these areas of resistance, they're heterogeneous. You know, we can see multiple things. And so while tepotinib in this scenario may affect MET amplification, there could be a diverse array of alterations, and we view these alterations as subclonal. And so that's why it's important to keep the osimertinib going initially, and then to attempt to control these subclonal alterations. But in the setting of a diverse subclonal process, that might be difficult even with tepotinib alone as an addition to osimertinib. So I think this field is very much evolving. I think there are multiple exciting therapies in this space, including the antibody drug conjugate HER3-DXd. That is exciting because it appears to have efficacy irrespective of the mechanism of resistance. But I think this trial highlights several important key points. Number one, make sure you're doing an NGS and biopsy in the setting of progression, because if you don't do that, you won't know. And number two, if you do see an actionable mechanism of resistance, such as MET amplification, the addition of tepotinib is quite reasonable and I think would be supported in a peer-to-peer conversation with insurance companies. And thirdly, there are a lot of exciting therapies on the horizon.
Thank you so much for going over that data and very clinically relevant. Now let us look at Codebreak 200 study focusing on KRAS mutated patients. Dr. Royce, your thoughts on its primary and secondary endpoints, and what should we take away from this study in community at this point in time?
Sure. So, as a background, KRAS mutations are frequently encountered in advanced non-small cell lung cancer, probably on the order of 30 to 35%. KRAS G12C is probably the most common alteration of that, seen in around 15 to 17% of patients. And for the longest time, this was not a druggable target. But recently, the science has evolved, and we've been able to develop targeted therapy specifically for KRAS G12C, though there are others in the pipeline. And the initial results that actually led to the accelerated approval of this drug were from the Codebreak 100 trial. And so this was a single-arm study that enrolled patients with advanced KRAS G12C mutated non-small cell lung cancer previously treated. And we saw exciting results from this, with response rates on the order of 40%, median progression-free survival of 6.3 months, and a median survival of around 12.5 months. This was exciting, obviously, finding a new druggable target for an alteration that was not druggable at the time. But what we didn't know is how this therapy compared to our standard subsequent line therapy, docetaxel. And so the Codebreak 200 phase 3 study was the proper randomized trial to evaluate this, randomizing patients with KRAS G12C mutated advanced non-small cell lung cancer previously treated who were randomized to either sotorasib or docetaxel. Now, importantly, this study was modified. You mentioned the design. The design was modified, and actually the sample size was reduced from 650 to 330 patients, and crossover was allowed from docetaxel to sotorasib, which I think was the appropriate decision here. I don't think you could not allow crossover, knowing that sotorasib had an accelerated approval in this setting. So I think it was the right decision. But unfortunately, it limited our ability to evaluate overall survival from this study. And so why is that important? Well, the primary endpoint of progression-free survival, this was a positive trial where the hazard ratio for PFS benefit was 0.66. The median progression-free survival was 5.6 months for sotorasib and 4.5 months for docetaxel. And so while that was important, and we were grateful to see that. In addition, a 12-month PFS of 24.8% versus 10.1%, so an over doubling of 12-month progression-free survival. The overall survival data did not show a statistically significant benefit. In fact, the hazard ratio was 1.01. But again, the important caveat there is that the sample size was insufficient to formally have enough power to evaluate overall survival. And there was crossover. 36% of patients went on to receive crossover sotorasib. So what's important? What's the important takeaway here? I would say that the study definitely did confirm the benefit of sotorasib. Another important point is toxicity. And so we did see that around 10% of patients saw 10% of patients developed grade 3 or higher diarrhea on sotorasib, and another around 9 to 10% saw grade 3 or higher transaminitis. And I think that points to a question of, does prior immunotherapy impact the development of these toxicities like we've seen with other targeted therapies? There is some retrospective data to suggest that over 90 days out from immunotherapy, the rates of high-grade transaminitis and other toxicities is lower. But obviously in clinical setting, you can't wait 90 days. If someone progresses, you're going to have to move on to this therapy. And while, again, the toxicity wouldn't take me away from that therapy, it's important to monitor closely for the development of transaminitis in those who have previously received immunotherapy.
Yeah, though this did not show OS, KRAS inhibitors still remain a very good viable options for our patients along with docetaxel.
Absolutely. And I do, again, I still, if you have a patient with KRAS G12C mutated non-small cell lung cancer who's progressed on a frontline chemoimmunotherapy strategy, I will still 100% go to sotorasib. But I think us in the academic community, we're a little disappointed that we didn't see that translate to an overall survival benefit, with the caveats, obviously, that we mentioned: crossover, smaller sample size, and I should say docetaxel appeared to overperform compared to historical data as well.
So,
Dr. Royce, thank you so much for taking the time to discuss these practice-changing studies with us today. We hope that our community medical oncologists will get a chance to incorporate what we have discussed here. Well, thank you so much again for your time.
You're welcome. Thank you for having me. And for those listening, you can find me on Twitter at Joshua_Royce, last name Reuss. Feel free to direct message me with any questions. I'm always happy to discuss patients and any clinical conundrums and concerns that you're having.